Welcome back to the Deep Dive, the place where we take the most complex information, distill it down, and give you the essential knowledge you need to be truly informed.
Today, we're undertaking a deep dive into a disease that is often called the Great Masquerader.
A diagnosis that's frequently missed, critically urgent, and involves an invisible enemy operating inside the body.
That's right. We are diving into cardiac amyloidosis, or CA. This is not a disease caused by high cholesterol or hypertension or even, the usual lifestyle factors.
Right.
It's a fundamental internal manufacturing defect where certain normal proteins produced either in your liver or your bone marrow, they become unstable, they misfold, and then they turn into these sticky, organized deposits.
Sticky deposits. That phrase really captures it, doesn't it?
Yeah.
We're talking about something like biological glue hardening the most vital muscle in the body, the one that can never take a rest.
Essentially, yes. This glue, which we call amyloid, it accumulates in the extracellular space.
So the area between the heart muscle cells.
Exactly. And so instead of the heart walls being flexible, able to relax and fill efficiently, they become progressively thick, stiff, and restrictive.
It just chokes the heart's function over time.
It does. And that process steadily leads to severe end-stage heart failure.
Okay, let's unpack this and state our mission clearly, because this is one of those deep dives where the information is immediately actionable.
It really is.
Cardiac amyloidosis is so often misdiagnosed as just, generic heart failure.
Mm-hmm.
But knowing the precise type is not just academic, it is immediately life-saving.
Absolutely.
We have to learn how to distinguish between the two major types, AL versus TTR, because the treatment for one will actually harm or even kill the patient if they have the other. And in some cases, time is measured in months, not years.
The clock is the most critical element here. We're going to look at the two major types, the unique systemic clues that can precede the heart failure symptoms by years, and the cutting-edge diagnostic imaging that finally allows us to non-invasively identify the culprit protein.
So before we get into the specifics of AL and TTR, we have to grasp the umbrella concept. What makes amyloid amyloid? What's the unifying feature of this disease?
Well, to understand the damage in the heart, we first have to recognize that amyloidosis is a systemic issue. It's defined as a systemic disease characterized by the deposition of fibrillar proteinaceous material in the extracellular space.
Okay, that's a mouthful of jargon.
It is. But the key phrase there is fibrillar proteinaceous material.
So no matter which precursor protein we're talking about, whether it's a light chain from the bone marrow or transthyretin from the liver, once it becomes amyloid, it takes on a specific, unified physical and chemical structure. Is that right?
Precisely. The precursor proteins vary widely, but the unifying characteristic of all amyloid is its staining properties and its microscopic structure. And this is a truly crucial piece of diagnostic information that has stood the test of time.
Okay.
If a pathologist takes a tissue sample, the defining chemical signature is that it stains with Congo red dye.
Congo red. Simple enough. But the real aha moment for the pathologist comes next, right?
It does. After staining with Congo red, when you view that sample under polarized light microscopy, the deposits exhibit a characteristic apple-green birefringence.
Apple-green birefringence.
Yeah, think of birefringence as the way light splits as it passes through an ordered material. The specific, tightly organized, misfolded structure of the amyloid fibrils causes that distinctive bright apple-green glow against a dark background.
That is a diagnostic catchphrase you definitely won't forget. It's like a visual fingerprint. So regardless of where the faulty protein came from, if it stains this way, it is amyloid. Why is that specific physical structure so important?
Because that unique physical structure is what dictates its function, or rather its malfunction. If you were to look even closer with, highly specialized electron microscopy, the deposits consist of these tiny, non-branching fibrils, roughly 10 nanometers in diameter.
And they're rigid.
They're rigid and ordered, and this is why they behave like a restrictive, unyielding glue in whatever organs they infiltrate. They physically block normal cellular function.
And focusing specifically on the cardiac aspect, amyloid cardiomyopathy, our sources highlight two primary precursor proteins that are responsible for the vast majority of cases, at least in the Western world.
That's absolutely right. These are AL, which stands for light chain, and TTR, which stands for transthyretin. We have to be able to tell these two apart rapidly because treating AL with the TTR drug, or vice versa, isn't just ineffective.
It's a fatal mistake. It just uses up the patient's remaining time.
Exactly.
Okay, let's start with AL amyloidosis, the light chain type. Based on the data, this is the one where the urgency is highest and the clock is ticking the loudest.
It is. AL amyloidosis is fundamentally a plasma cell disorder. It's born in the bone marrow, where these cells live. Plasma cells are the specialized white blood cells that make antibodies.
And it's related to multiple myeloma.
It's very closely related, and in fact, sometimes overlaps with it.
So if the plasma cells are the source, what exactly are they doing wrong? Can you quickly define plasma cell dyscrasia for us, just in simple terms?
A plasma cell dyscrasia means there is an abnormal cancerous clone of plasma cells, and instead of producing normal, complete antibodies, these faulty cells are producing excessive amounts of just one component: free light chains.
Either the lambda chain or the kappa chain.
Right, lambda is more common, and these abnormal standalone light chains are the ones that misfold and become the sticky amyloid deposits that go on to infiltrate the organs.
And because the source is systemic, the whole bone marrow, it's rarely confined to just one location.
Exactly. It is frequently a multisystemic disease. And while it can involve many organs, the heart and the kidney are the two most common and clinically relevant organs involved, often at the same time.
The urgency here needs to be shouted from the rooftops. If the heart is involved, what is the prognosis for AL?
Cardiac involvement carries the worst survival rate of any type of amyloidosis. I mean, in untreated patients, the median survival from the onset of heart failure symptoms is only about 6 months.
6.
It's why we stress the need for recognition. That short survival window underscores the absolute necessity for rapid diagnosis, often within weeks, and immediate specific therapy that targets the bone marrow.
It is terrifying. It means we cannot wait for classic heart failure symptoms to become definitive. It puts a huge premium on recognizing the non-cardiac clues, the subtle systemic red flags.
Yes.
What are these definitive red flags for AL?
We must look outside the cardiovascular system. Since kidney involvement is so common, we look for significant proteinuria, that's excessive protein leaking into the urine, which can then lead to low protein levels in the blood. Neuropathy is also common.
But the two visual clues are the ones that are truly unique to AL, aren't they? The ones that are just unmistakable.
They are. The two visual signs that should instantly jump out are periorbital purpura, which is often described as raccoon eyes.
Bruising around the eyes.
Right. It happens because the amyloid fibrils infiltrate the delicate blood vessels in the skin, making them fragile and prone to rupture. This happens in about 20 to 30% of cases.
That's a huge distinctive clue. 20 to 30% is frequent enough to be a mandatory check in any patient who presents with unexplained heart failure.
The other visual clue is macroglossia, an enlarged, firm tongue, which is due to amyloid infiltration of the tongue muscles. This occurs in about 10% of cases.
So if you see heart failure combined with raccoon eyes or a stiff, enlarged tongue,
AL amyloidosis should jump immediately to the top of your differential list. These signs are virtually pathognomonic. They are the disease speaking clearly.
that's a critical lesson. A cardiologist suddenly needs to be a detective looking at the patient's eyes and tongue for clues that are coming from the bone marrow.
Absolutely.
Okay, now let's pivot to TTR amyloidosis. This disease starts with a completely different source protein, transthyretin, or TTR. This protein is primarily produced in the liver.
Yes, and it's responsible for transporting thyroid hormone and vitamin A. So unlike AL, this is a liver problem, not a bone marrow problem.
And that difference in origin fundamentally changes the nature of the disease and how it presents. I understand we break TTR down into two categories, wild type and variant.
That's right.
Let's talk about wild type TTR first. It's sometimes called senile or age-related amyloidosis. The source material notes it used to be considered rare, but now it's recognized as the most common form of cardiac amyloidosis overall. Why that shift?
It's all about improved diagnostic technology. Primarily the nuclear scans we'll discuss later. They've just exposed how prevalent this really is.
So this is the version where the TTR protein is genetically normal.
Structurally normal, yes. But due to the stresses of aging, it just becomes unstable over time. It breaks apart, misfolds, and forms those amyloid fibrils. It affects mainly older men, typically presenting in their 70s and 80s and onward.
And the gender disparity is astounding. Why is it 20 times more likely in men than women?
That is still an area of intense research, but the leading theory involves hormonal influences. It's hypothesized that estrogen might confer some kind of protective effect against the TTR protein becoming unstable.
Interesting.
And when it does occur in women, it tends to present later, often in their 90s, and it generally follows a slower, more indolent course.
So, comparing the untreated trajectory to AL's 6 months, what does the prognosis for wild-type TTR look like?
The untreated median survival from the onset of heart failure is significantly longer. We're talking around 4 to 5 years, Death is usually due to progressive congestive heart failure.
So still a life-limiting disease, but it gives clinicians years, not months, to
And
intervene.
exactly. And crucially, in contrast to AL's multi-organ involvement, the heart is typically the sole major organ clinically involved in wild-type TTR.
So the batter is isolated to the heart. That's a major diagnostic distinction. However, TTR does have its own unique long-term systemic red flags, right? Mainly involving connective tissues, ligaments, and tendons.
This is perhaps the most important clinical insight for catching TTR early. TTR has a specific predilection for depositing in these connective tissues. And in about half of the patients, if you ask the right questions, you can find a history of ligament and tendon issues.
And this is happening years before the heart failure.
An astonishing 5 to 8 years before they present with heart failure symptoms.
5 to 8 years. So a cardiologist is essentially asking a patient about their orthopedic complaints from a decade ago. What specific complaints are we looking for?
The three most common precursors are carpal tunnel syndrome, often bilateral, requiring surgery, severe spinal stenosis requiring multiple lumbar decompression procedures, or a history of a non-traumatic ruptured bicep tendon.
And the thinking is that the TTR deposits cause thickening and inflammation in the tendons, leading to these early surgical problems.
That's the idea. So this means we have a clinical opportunity to catch this disease long before the patient develops severe heart failure just by looking at their surgical history. It completely changes the diagnostic paradigm.
It really does.
Yeah.
Now, then we have variant TTR, the familial or mutant type.
Yes, this is caused by genetic mutations in the transthyretin protein itself. It's the form that's passed down through generations.
And this form is much more likely to involve the nervous system, leading to neuropathy, correct?
Yes. Variant TTR is classically associated with amyloid neuropathy. This can range from, mild sensory issues to a rapidly progressive severe sensorimotor neuropathy, and importantly, it often includes involvement of the autonomic nervous system.
The nerves that control involuntary functions like blood pressure?
Exactly.
The source material highlighted a specific variant that's very common in the U.S. population.
That is the Val112B2-IL variant, which is the most common mutation in North America. It involves a valine substituted for isoleucine at position 122 of the protein.
And it's carried by about 3.5% of the U.S. population of African descent.
That's right.
Does it present differently from the wild type?
It generally presents as a late-onset restrictive cardiomyopathy, usually in the 7th decade or later. Interestingly, for this specific variant, the associated neuropathy is often mild or even absent.
But the tendon signs are still there.
The tendon signs are often still present. Carpal tunnel syndrome commonly precedes the onset of heart failure by several years, just like in the wild-type form.
And untreated, the prognosis here is a little faster than the wild type.
Yes, the median survival is about 2 to 3 years following the onset of heart failure, placing it somewhere between the highly aggressive AL and the slower wild-type TTR.
There's a fascinating note about neuropathy actually masking or reducing cardiac symptoms in variant TTR. That feels counterintuitive.
It is. It's a physiological trick of the body. The myocardial infiltration can be extensive, meaning the heart is severely diseased, yet the cardiac symptoms might be relatively mild.
Why does that happen?
It happens for two main reasons. First, the patient's limitation of physical activity because of their peripheral neuropathy. It masks their exercise intolerance. They simply can't walk far enough to push their failing heart into acute symptoms.
They aren't demanding enough from the heart to expose the failure. What's the second reason?
If autonomic neuropathy is present, meaning the nerves controlling the blood vessels are affected, it can cause peripheral vasodilation. The blood vessels remain too relaxed. This acts to reduce peripheral resistance, effectively decreasing the overall workload the heart has to pump against.
Less work means fewer severe symptoms, even with a really stiff heart.
Exactly. It makes the diagnosis even slipperier.
So if autonomic neuropathy is suspected in AL or variant TTR, what is the mandatory physical check a clinician must perform?
The mandatory check is for highly symptomatic postural hypotension. This is when the patient experiences a severe drop in blood pressure and often dizziness or even fainting when they stand up.
And if that's present?
If it's present, it points strongly toward autonomic neuropathy, which is a key feature of AL and variant TTR, but is typically not seen in wild-type TTR. That's a crucial differentiator.
So summing this section up, regardless of whether TTR is wild type or mutant, both have a subclinical phase that likely lasts many years while the amyloid is just slowly accumulating.
Absolutely. By the time the patient develops clear signs of heart failure, there has been progressive infiltration. And get this, 30 to 50% of the involved heart weight is now due to this non-functional amyloid deposition.
Wow. And before the severe mechanical heart failure, the presenting symptom can often be electrical in nature, right?
Yes. Atrial arrhythmias, most commonly atrial fibrillation or atrial flutter, may be the very first feature of the disease that brings the patient to clinical attention. And when they occur, they often precipitate or severely worsen the existing heart failure.
Because that stiff heart is just completely intolerant of losing the coordinated pump action of the atria.
It needs that atrial kick. Without it, things can go downhill very fast.
We've established that AL and TTR have radically different systemic origins, prognosis, and precursor symptoms. Yet when the patient arrives at the clinic, the cardiac features are often surprisingly similar.
They can be, yes, which reinforces the need for precise typing.
So what does the typical heart failure presentation look like?
The most common clinical presentation is congestive heart failure, but it has a very specific flavor. While both the left and right ventricles are usually heavily infiltrated, patients tend to present clinically with symptoms of predominant right heart failure.
Why the right side preference in the symptoms?
Well, the heart is encased in this restrictive layer. When the heart can't fill, the pressure backs up. And so symptoms like severe peripheral edema, swelling in the legs, and often ascites, which is fluid accumulation in the abdomen, are hallmarks of the right ventricle failing to accept blood from the body.
But catheterization would show high pressures on both sides.
It would. Cardiac catheterization confirms that both left and right ventricular filling pressures are high, but the right-sided symptoms are often what force the patient to seek medical help.
Let's walk through the physical examination findings that just scream restrictive cardiomyopathy. What are the critical clues?
Okay, first, hemodynamically, the patient will generally have a normal or low pulse pressure, which reflects the stiffening and the low stroke volume. Second, that mandatory check for a postural drop in blood pressure, which links back to AL or variant TTR.
The famous neck vein sign, the jugular venous pressure, is critical here.
The jugular venous pressure, or JVP, is almost always visibly elevated. It just reflects that high right-sided pressure. And frequently, it demonstrates a specific, highly suggestive finding called a Kussmaul sign.
Can you elaborate on the Kussmaul sign? What exactly is a paradoxical rise in JVP on inspiration?
Normally, when you breathe in, the pressure inside your chest decreases, and that pulls blood into the heart, so the JVP should drop.
Right.
In a restrictive heart, the stiff ventricles prevent that increase in venous return from being accommodated. So instead of dropping, the JVP paradoxically rises because the heart simply cannot expand the vein to take in the extra blood load. It's a very strong sign of restriction.
That makes perfect sense. The heart is encased in a stiff box. Now, it's interesting that despite this severe congestive heart failure, the characteristic extra heart sounds we often associate with heart failure, like S3 or S4 gallops, are very rare here. Why are they silent?
That's entirely due to the restrictive pathophysiology. The stiff ventricular walls impair ventricular relaxation, which prevents the turbulent blood flow that generates an S3 sound.
And the S4?
Well, an S4 sound is caused by the atrium forcefully contracting against a stiff ventricle. But in amyloid, the infiltrated atrium itself is often so stiff and dysfunctional that it just can't generate enough contractile pressure to produce a loud sound.
So both the ventricle and the atrium are too stiff to make the classic sounds.
Exactly.
And regarding heart murmurs, is valve disease common due to the infiltration?
Amyloid-associated valve disease is relatively uncommon. You might see some tricuspid regurgitation simply because the right side of the heart dilates under high pressure. But, interestingly, there is a noted association between aortic valve stenosis and TTR amyloidosis.
The main outflow valve of the heart.
Yes, it's suspected that the amyloid accelerates pre-existing degenerative changes in the valve, precipitating heart failure earlier than you would otherwise expect.
Beyond the cardiovascular exam, the systemic examination differentiation. We mentioned the AL-specific signs like purpura, but what about the liver?
Hepatomegaly, an enlarged liver, is common simply due to the intense central congestion from the heart failure. However, a key differentiator is that an unusually hard liver on physical examination may suggest actual amyloid infiltration of the liver tissue itself.
And that points to one type over the other.
It does. This specific infiltration occurs in AL amyloidosis, but not in TTR amyloidosis. It's another vital clue to distinguish the aggressive type without needing a biopsy.